So guys, now let's talk about the tracts of the spinal cord, in which we'll first look into the ascending tracts and then the descending. Uh, in fact, in the ascending tracts, first we need to find out the location of the ascending tract, that which part of the spinal cord they are present in. Are they in the dorsal side of the spinal cord, or toward the lateral side, or toward the anterior side? Because that will also help us to understand that how second order neuron actually reached there. Secondly, then we need to see that which nuclei they are connected to. We just discussed nuclei like substantia gelatinosa, nucleus proprius. So how these are connected to the certain gray matter nuclei. Also, what tract are carrying what kind of sensory input inside. Which one is for pain and temperature, touch and pressure. So as I said, the sequence of the tract discussion should be like knowing the where the tracts are located in the spinal cord, what are the sensations they are carrying inside, which gray matter nuclei they are connected to, and then we're going to take all these major three tracts separately one by one in detail and see how exactly they reach the cerebrum or cerebellum. So let's begin with the ascending tracts. So first thing, location and their function. So again, I would request you to draw it toward the left side only. So again, the transverse section. And this time, because we're discussing the white matter, we're discussing the tract. So make sure you draw the gray matter a little less so that you have more space for the white. Okay. So when you look at the ascending tracts, we have a tract occupying the dorsal part of the spinal cord, or you say the dorsal fasciculus of the spinal cord. All these terms like fasciculus, bundle, peduncle, crus, lemniscus, funiculus, they all means white matter only. They're just different name given to the white matter, different level. Like in the spinal cords, at some time we call this as a fasciculus over there. We also can call it funiculus. Tracts, when they reach the brainstem, they are called as the term given to this lemniscus. Crus cerebri, the word crus is again for the white matter itself. So different name given to the white matter, different part of the spinal cord and the brain. So in the dorsal aspect of the spinal cord, we have a tract which is called as a dorsal column tract only, and this dorsal column tract is having two components. We got two components of dorsal column tract. The one which is medially placed is called as a fasciculus gracilis. This is called as the fasciculus gracilis. And here we have fasciculus cuneatus. Fasciculus gracilis and fasciculus cuneatus. Gracilis and cuneatus. Now together they are referred as the dorsal column tract. Together they are referred as dorsal column tract because they are occupying the entire dorsal aspect of the spinal cord. If you see this, everything in the dorsal aspect is occupied by these tracts, so we call it dorsal column tract. Fasciculus gracilis and cuneatus, the two bundles you will see in there. Guys, gracilis are those fibers which are coming from the lower limb, and cuneatus fibers are coming from the upper limb. Gracilis from the lower limb and cuneatus from the upper limb. And the easy way to remember it, gracilis, look at the term gracilis. Gracilis reminds you of lower limb, although it has nothing to do with that muscle. But we all know that gracilis muscle is a muscle of lower limb. So from that you can remember that lower limb fibers are present in this bundle which is called as fasciculus gracilis. What exactly is the function of this tract? This dorsal column tract, whether it is coming from upper limb or lower limb, the function is it is carrying, number one, it is carrying the conscious proprioception. Conscious, guys, it's conscious proprioception. Then we have fibers of fine touch. Fine touch. Well, to an extent, pressure also, although this is not the major tract for pressure, but yes, pressure does go through this tract also, but this is not the major tract for pressure. Vibration for sure, and stereognosis. You know what stereognosis is? Stereognosis is just the ability to recognize the object by touching it. I mean, if I take a water bottle, if I don't look at it, I can just turn my head on that side, I can touch the water bottle, I can feel it that this is a water bottle. And that is a stereognosis, ability to recognize something by touching it. So obviously that stereognosis can be done mainly with the upper limb. So when I talk about the stereognosis type of sensation, we are focusing in the stereognosis to the upper limb part, to the fasciculus cuneatus part. If I have to say stereognosis, obviously I'll be focusing on the cuneatus portion. So this is the dorsal column tract having two components coming from the lower limb and upper limb. And you should also remember that which one is medial and which one is lateral, because sometimes they might give you an image based question in which they might show you a lesion of a particular part. And see, again, it makes sense that the lower limb fibers are present more toward inside and upper limb are outside. Because imagine you start thinking about the tract from the lower aspect. We have a spinal cord tract and imagine it in the lower aspect here. So when the lower limb fiber comes inside, they get accumulated in the spinal cord, but where? They will first occupy the very medial part of the spinal cord. So that once the spinal cord reaches here, at this point, we already have fasciculus gracilis in it because they were coming from lower limb. Now fasciculus cuneatus fiber are also added to it. So they will be added there outside of them. So the one which is starting before, early, is the one which is inside, and the one which is coming on later is outside. It's like just you're filling up water in a glass. Obviously, the water which is the part of water which you filled in early was below, and the later one is above. The same thing only. So when the fibers are coming inside from the lower limb, because these are sensory fibers, when they're coming inside, they get accumulated to the inner part of the spinal cord, and the one which are accumulated to the outer part of the spinal cord are the one coming from upper limb. So that way you can remember that which one is inside and which one is outside. Then we have a very important tract present in the lateral part of spinal cord, and this is divided in two parts. We have like divided in two bundle. Now see, it is present where? In the lateral part of spinal cord, but the name of the tract will be, this will be called as the dorsal, and this is called as ventral. Now don't confuse with the word dorsal and ventral here. They are dorsal and ventral with respect to each other. They are dorsal and ventral with respect to each other. They are both in the lateral side, but you have to say which one is posterior, which one is anterior. So this one is posterior, this one is anterior. Dorsal and ventral spinocerebellar tract. Dorsal and ventral spinocerebellar tract. Obviously going toward the spinal cord, to the cerebellum from the spinal cord. And spinocerebellar tract, obviously when you look at the word cerebellum, you can easily make out that what their function would be. They are carrying the unconscious proprioception. Unconscious proprioception. Conscious proprioception was going into the cerebrum. That is, it has to go to the cerebral part. Unconscious goes into the cerebellum. And finally, we got a tract present partly in the lateral aspect of the spinal cord, lateral part of the white matter of spinal cord, and partly in the anterior. And that's how they're named also. So this is present toward the lateral side, so we call it lateral. Spinothalamic tract. This goes to the thalamus, that is lateral spinothalamic tract. And this one is present ventral or anterior. So we call it anterior spinothalamic, or you can say ventral spinothalamic. Anterior spinothalamic tract. Lateral and anterior spinothalamic tract. Well, the function. Lateral spinothalamic tract, the important one, the function is to carry the pain and temperature. It carries pain and temperature, whereas anterior spinothalamic tract is the one which is carrying the crude touch, and this is the major tract for the pressure. Crude touch and pressure. And when I say pressure, you can underline this, that if you have to choose one tract for the pressure, if you have option to choose between the two, definitely go with anterior spinothalamic. Pressure is carried by the dorsal column tract also, but mainly the pressure goes into the anterior spinothalamic tract. Now, what happened here is, we saw the location of the gray matter already, gray matter nuclei, and now we are looking at the location of white matter, which gives me a fair idea to trace the ascending tracts from its origin to its termination. Now think about, guys, the tract obviously is starting from any peripheral nerve which will carry the sensation from outside. Whether let's take an example, pain and temperature is carried from the forearm region here, from the skin of the forearm, will go inside, and then because it is pain and temperature. So what is the nuclei? If you remember in the previous discussion, nuclei for the pain and temperature. So those fibers will go from the dorsal aspect of the spinal cord and will go into substantia gelatinosa, because that was the nucleus for pain and temperature. From the substantia gelatinosa, the second order neuron will start, and those second order neuron are the one which will come into this white matter of spinal cord. Which tract is for pain and temperature here? Lateral spinothalamic tract. So from substantia gelatinosa, from there inside, what will happen from the substantia gelatinosa, the fibers from here, they will come into this part, lateral spinothalamic region, and then they will ascend upward, reach certain part of the thalamus where they will relay, and there from again the next neuron will start, which will go into the cerebral hemisphere. So before we start discussing these tracts one by one, just keep it in mind that our main goal here is to identify where we have first order neuron, where is the second order neuron, and where is the third order neuron, and does there any decussation takes place or not, and if it does, exactly at what level. Because knowing the level of decussation is very, very important if you want to understand the syndromes or the lesions of the spinal cord. Because if you don't know the exact level of decussation for ascending and descending tract, then we always will have a problem in understanding whether the effect will be on the ipsilateral side or contralateral side, or maybe bilaterally present. So that's why the decussation thing is very, very important. So in that sequence, so we have three tracts: dorsal column, spinocerebellar, and spinothalamic. I want to start the discussion with the spinothalamic tract first. Spinothalamic tract. Okay. Now, for obviously any tract which is going toward the cerebrum, the highest center here is the cerebral cortex. So let us say, let's draw the plot first, guys. This is the sensory cortex in the cerebrum, that is sensory cortex. And I hope you know that sensory cortex area number is 3, 1, and 2. The Brodmann's classification 3, 1, and 2. You should not call it 3, 2, 1 or 1, 2, 3. It should be 3, 1, and 2. That is sensory cortex. The highest sensory nuclei is thalamus. So all the sensory input, most of them, they first go into the thalamus and then they go beyond the thalamus into whatever part. Now, thalamus, but which nuclei of the thalamus, that is also important, guys. It is VPL nucleus of thalamus, which we are bothered about right now. VPL. What is VPL? Ventro-posterior-lateral. Ventro-posterior-lateral nucleus. How will you remember that which sensation goes into VPL and which sensation goes into VPN? That's a very easy way to remember it. If I may take you away from this discussion for 1 second, we'll come back to this. So we said thalamus is having an important nuclei called as VPL, that is ventro-posterior-lateral, and there's a nucleus called as VPM, ventro-posterior-medial. I would say, think of these words. These are the two words which are different here. Ventro-posterior is there in both. One is lateral, one is medial. So L and M will help you here. So when you say L, this should remind you of lower. Now lower, what we'll see? Lower. And when I say M, M should remind you of mouth. Just a hint, and this will help. VPL, ventro-posterior lateral nucleus, that means sensory fibers which are coming into this are coming from the lower part of the body. And when I say lower part of the body, that means lower to mouth. The mouth is here till here. So fibers which are present below. So any sensation of like pain, temperature, touch, pressure, whatever, if it is coming into the thalamus, then it will go into which nucleus? It will go into the VPL nucleus. But if the sensation is coming from the face or the mouth, like taste sensation, like trigeminal nerve, is carrying the sensation from this face or the upper part here, so they will all go into this VPM nucleus. So that's an easy way to remember. L and M. Lower, mouth. Lower and mouth. Okay. So because we are talking about the sensation which are obviously coming into the spinal cord and above, so it has to be the VPL. Any sensation which is related to the spinal cord, which will go into the thalamus, VPL nucleus of thalamus. Then from this thalamus, if I draw a midline, now let's assume this here is a midline of the brainstem and spinal cord. This is the midline of the brainstem and the spinal cord both. And here is the spinal cord here. Let us draw the gray matter also, just to clearly see where the fibers will be present. So that is, let's say, that's a thalamus part, that is a part of diencephalon, of course, and we're just presuming a midline of the brainstem all the way extending to the spinal cord. So this is the plot we need to understand the spinothalamic tract. I need a cortex, sensory cortex, the thalamus, and the spinal cord here. Any sensory information coming from outside is going to come inside through the dorsal root ganglia, DRG, dorsal root ganglia. Dorsal root ganglia is going to be the first order neuron, for any pathway you're talking about coming from the spinal cord. Obviously, any sensation going into the spinal cord will go through the dorsal root ganglia. So that is giving rise to the first order neuron for every pathway here. Now, right now we are talking about the spinothalamic tract. That means the type of sensation which will be coming through this dorsal root ganglia are pain and temperature, crude touch and pressure. Pain and temperature, crude touch and pressure. So all the sensation which are coming through the dorsal root ganglia inside right now, because we are talking specifically about one tract here, pain, temperature, crude touch or pressure, whatever it is, they're all collectively coming through the dorsal root ganglia into the dorsal horn of the spinal cord. And there's a nucleus which is present here, which is called as the substantia gelatinosa. That is going to be the main nucleus here. That is substantia gelatinosa. Let me just label that here only. Substantia gelatinosa. You already know that. So this is going to be the end of first order neuron. Now guys, second order neuron will start from substantia gelatinosa, and you can say that it's the property of substantia gelatinosa which can differentiate between the pain and temperature and crude touch and pressure here. That means pain and temperature fiber will go separate and crude touch and pressure fiber will go separate here. So from the gelatinosa part here, the second order neuron will start, and the property of second order neuron here is that they will decussate at the level of spinal cord itself. They will not wait any further. So we have a second order neuron starting from here, will decussate at the level of spinal cord, will go to the lateral side, and some fibers will decussate and will go toward the anterior side of the spinal cord. Some to the lateral side, some to the anterior side. You already know those fibers which go toward the lateral side will form lateral spinothalamic tract. That's why the location is laterally placed, this one. And the one which is going to come to anterior, that is anterior spinothalamic tract. So in their respective position only, you will see these tracts will ascend upward in the respective part of the spinal cord and the brainstem to reach thalamus. And they are going to relay in the thalamus. You already know which nuclei of thalamus we said, that is a VPL nucleus of thalamus. You got my point? So second order neuron is starting from the substantia gelatinosa, decussating at the level of the spinal cord, giving rise to two tracts here. One which is carrying the pain and temperature, this is the one, and the one which is carrying crude touch and pressure, this is the one. Let me name these tracts in the lower part only here. So at the level of the spinal cord only, this tract will be called as a lateral spinothalamic tract. I'm writing in short, LSTT, lateral spinothalamic tract. Whereas this tract here will be named as anterior spinothalamic tract. You already know the difference, guys. You already know the difference. Anterior was carrying the crude touch and pressure, and lateral spinothalamic tract was carrying pain and temperature. So now we have these fibers separated. Now there is a thing that you should know. What order neurons we said these are? These are second order neuron. Now you can note this down somewhere, that in the nervous system, if a sensory tract is decussating, it is done by the second order neuron only. Any tract you take, any tract, ascending tract, sensory tract I'm talking about, not motor. Any sensory tract or any ascending tract you talk about, if it is decussating, only second order neuron will decussate. Neither first order nor third order, it's a second order neuron which will decussate. Now, I want you to understand this statement very well, because I'm not saying that every second order neuron will decussate. The tract which decussates, for that tract, only second order neuron can decussate. Now, there are certain tracts which will not decussate. We do have some sensory tracts which are running on the same side only and then never go to the other side. And they do have first order, second order, third order neuron, everything is there, but still they are not decussating. Well, that's a different case. If a tract is decussating, let's say, then it can decussate only using the second order neuron, and doesn't matter where the tract is. At the level of spinal cord, they still decussate, that is second order neuron. If it is higher, like think of optic nerve, guys, optic chiasma. Optic chiasma is formed by the second order neuron only. So any sensory tract you talk about, it's the second order neuron, they decussate only. Another important information that you should know, that once these tract, they decussate to other side and reach in the brainstem. Now this is spinal cord, somewhere here will be brainstem. Once these tract, they decussate and reach the brainstem, the name changes to lemniscus. These tracts in the brainstem are referred as lemniscus. Lemniscus means white matter only, so they are referred as lemniscus. Like this lateral spinothalamic tract which is carrying pain and temperature, this is called as what lemniscus? This is called as the spinal lemniscus. Spinal lemniscus. A very common mistake people does. They think the name is lateral spinothalamic tract, so it should be lateral lemniscus. No. Lateral lemniscus is auditory pathway. So lateral spinothalamic tract, which is carrying pain and temperature, you already know that, is forming the lemniscus in the brainstem called as spinal lemniscus. On the other hand, anterior spinothalamic tract ascending in the brainstem is going to join with the lemniscus called as medial lemniscus. And I'm writing this thing, guys, joins. It joins medial lemniscus. That means this is not the only tract forming the medial lemniscus. There is some other tract also. It is just a part of it. It joins medial lemniscus. Let me just give it a same color. Anterior spinothalamic tract carrying crude touch and pressure is going to join the medial lemniscus. So obviously these lemniscus are also which order neuron? They are also the second order neuron. It's just that the name you have to remember. We call it spinal lemniscus in the brainstem. In the spinal cord, we were calling it lateral spinothalamic tract. Similarly, here is a medial lemniscus. In the spinal cord, it was anterior spinothalamic tract. This you have to know. Which also gives me one important information, guys. Injury to any lemniscus, doesn't matter whichever lemniscus you talk about. Injury to any lemniscus, medial, spinal, trigeminal, lateral, if there is injury to any lemniscus, the effect is always going to be on the contralateral side, because lemniscus are formed by those second order neuron which decussates. Lemniscus is always formed by those second order neuron which decussate and then ascend upward. That means injury to lemniscus, the effect is always toward the contralateral side. So just keep it in mind. Every time you hear a term injury to so and so lemniscus, the first thing should come to your mind is contralateral. The effect has to be contralateral. Now we reach the thalamus, and that is the end of which order neuron? That is second order neuron is done. Now it's the responsibility of thalamus to disintegrate this information and send it to the respective part of the cerebral hemisphere. Now cerebrum, like even the sensory cortex, is huge. Now which part of the sensory cortex? Even if it is a normal pain and temperature, like pain and temperature is coming, now pain is coming from where? Lower limb, upper limb, which part it is coming from? So that is differently represented in the sensory cortex. So that's the job of the thalamus, to receive these fibers, disintegrate them, and then radiate these fibers into the different part of the cerebral cortex. And that's why these fibers are called as a corona radiata. This third order neuron, which will start from the thalamus, and these third order neurons, they will project into the respective part of the sensory cortex. So because of this radiation like thing, this is called as a corona radiata. There is a corona radiata. But see, corona radiata, the problem with this word is, corona radiata is a very, very vague term. It's a very huge term. Corona radiata means all the ascending fibers and even descending fibers also. Whatever fiber you going into the cerebrum and coming from the cerebrum, they all form corona radiata only. So this is not only about the sensory. We are discussing a sensory tract, ascending tract. So yes, we can say corona radiata, but more precisely, More precisely, these fibers are called as thalamic radiations. Thalamic radiations, and that's our third order neuron. Thalamic radiation, which is a part of corona radiata. Thalamic radiation, which is a part of corona radiata, is our third order neuron, the one which are projecting into the different part of sensory cortex. So guys, this is how the spinothalamic tract is going to reach its destination. The sensation which came from outside, they will go through dorsal root ganglia as a composite information in a if I say in a single nerve in a way, and they go inside into the dorsal horn of the spinal cord in the substantia gelatinosa. They will separate. One fiber, second order neuron forming, taking the pain and temperature, goes toward the lateral side. Another second order neuron which is forming, carrying the touch and pressure, crude touch and pressure, goes toward the anterior side, and that's how they're named lateral and anterior spinothalamic tract. They keep ascending in that same side of the spinal cord, like this one is keep ascending anteriorly in the spinal cord as well as in the brainstem, and that will ascend laterally in the spinal cord and in the brainstem, and they have a name given to them in the brainstem called as lemniscus, spinal and medial lemniscus, which goes to the thalamus, and then finally third order neuron into the cortex. Now, out of crude touch, pressure, pain and temperature, the four information we are talking about here, which information is having thalamus as the highest center? Which of these information is having the thalamus as the highest center? And that is pain. So please note that, guys, pain is the thalamus is the highest center for the pain. So it's not going to go beyond that. All these pain gate mechanism, pain gate theory, they are all controlled at the level of thalamus only. Highest center for the pain is thalamus. Highest center for the pain is thalamus. So that was the first tract. I hope you understood this, the first, second, third order neuron concept here. And this was pretty easy because the decussation was taking place at the level of spinal cord. Why I'm saying it is easy? Because injury to the lateral spinothalamic tract, even if I say the word lateral spinothalamic tract, or if I say the word spinal lemniscus, injury is obviously here. So effect is on the contralateral side because the decussation has taken place at the level of spinal cord only. So it doesn't matter injury is at the spinal cord or at the brainstem, the effect is on the contralateral side. But you will not have the same simple arrangement for the other tracts like dorsal column tract. It's not the same story. So the second important major tract we're discussing here is the dorsal column. Once again, we're going to draw the same plot, guys. The sensory cortex here. That's the sensory cortex. 3, 1, 2, area number 3, 1 and 2. Once again, this here is the thalamus. And we are still talking about the sensations which are coming from the lower, from below. So what nucleus we still need to continue with? VPL, ventro-posterior lateral nucleus. L, lateral, lower. Once again, I would request you to draw the midline here. That's a midline of the brainstem. And this midline of the brainstem will continue as a midline of the spinal cord also. Just try to make it a little longer so that we can clearly show that where the decussation takes place. Okay, because we are discussing the dorsal column tract, so I'm leaving a little more space toward the dorsal side. And let me highlight the two tracts which we already know. One is the gracilis, which is toward the medial side, and we have cuneatus toward the lateral side. Okay, now understand this in a sequence, guys. The first order neuron, same story, dorsal root ganglia. So DRG, the dorsal root ganglia, I'm writing it twice because some are coming from lower limb and some from the upper limb. Now let's say these are the fibers coming from the lower limb. lower limb dorsal root ganglia, and there's an upper limb dorsal root ganglia. Whether it is upper limb and lower limb, the thing that you will notice here is that their first order neuron will start as DRG, which will go directly into the fasciculus gracilis and ascend upward to reach the brainstem. Just the brainstem only, don't go beyond that. And again, for the upper limb also, they will reach the fasciculus cuneatus and they will also ascend upward to reach the brainstem. Let me draw this arrow here. I know some questions might be coming to your mind. We'll answer it. Now, first, this is the fasciculus cuneatus. I'm writing FC here, and this is fasciculus gracilis. Dorsal root ganglia was which order neuron? They were obviously first order neuron. They were all first order neuron. So this, once the first order neuron reaches in there, we have the fasciculus cuneatus and fasciculus gracilis, which are still continuing as what order neuron only? The first order neuron only. They're still continuing as first order neuron only. Now, ideally, what should have happened, that these dorsal root ganglia should have gone inside the gray matter and relay into some nucleus over there. We have a nucleus proprius present over there. They should have relayed there, and then second order neuron would have come outside here. Well, no, that's bit exception there. We have some a different type of arrangement here. We will understand the reason for having the nuclei there. But if I simply go with dorsal root ganglia from the upper and lower limb, they're predominantly going directly into the white matter. So they're not going into gray matter. They're predominantly going into the white matter and ascending upward. Now the problem with the first order neuron is that if a tract wants to decussate, then the first order neuron can't do it, and they are still first order. So what will happen if I want to take this tract to the other side and then to the other side of thalamus? The first thing is to be done is that we need to relay the first order neuron, and then the second order neuron can decussate. So for the fasciculus gracilis and cuneatus in the medulla oblongata, they keep on ascending on the same side of spinal cord, but once they reach the medulla oblongata, they will find their nucleus in the medulla, which is called as the nucleus gracilis and nucleus cuneatus. I'm writing in short, you can write it separately somewhere, NG and NC, nucleus gracilis and nucleus cuneatus. That is nucleus gracilis and nucleus cuneatus, which is the end of these first order neurons. Where nucleus gracilis and cuneatus are? They are present in medulla oblongata. See, locations are very important. Then only you will understand the decussation. So once the first order neuron they relay in the nucleus gracilis and cuneatus, which is in medulla oblongata. From there, the second order neuron will begin. Now look at this. The second order neuron will begin, and we know the property. Second order neuron, they can decussate. There we have. They immediately decussate to the other side, and because they are decussating to the other side in the brainstem, in the medulla oblongata, in the brainstem, so when they ascend on the other side, the name will change to the lemniscus. We said that once the tract decussate, goes to the other side, ascend in brainstem, the name changes to lemniscus. So this is what you call as the medial lemniscus. Going to the same VPL nucleus only. So this lemniscus here, guys, is called as the Before I come to the medial lemniscus, first, what are these fibers called as? Now, those fibers which are decussating to the other side, so they are basically present in medulla oblongata, and they make an arc to reach the other side. So inside the medulla oblongata, making an arc and reaching the other side, and that's why the fibers are called as internal arcuate fibers. They arc. We call them internal arcuate fibers. Internal arcuate fibers. Which order neuron? Of course, second order neuron, because they are the one decussating. They are the one which is after the nucleus, so they are second order neuron. Internal arcuate fiber. And medial lemniscus also is a second order neuron. Now, I hope you understood the point of medial lemniscus here, because in the previous case we said about the medial lemniscus that anterior spinothalamic tract joins the medial lemniscus. Anterior spinothalamic tract is carrying what sensation? Crude touch and pressure. So crude touch and pressure is going to join the medial lemniscus. Which medial lemniscus? Which you are looking here also. This medial lemniscus, which is carrying the dorsal column tract, and dorsal column tract carries what? We just discussed, guys, dorsal column tract is for conscious proprioception, vibration, stereognosis, pressure. All that is done, carried by the fine touch. That is all by dorsal column tract, which goes into medial lemniscus. So overall medial lemniscus is having dorsal column tract in it, and anterior spinothalamic tract will also come and join with it. So injury to medial lemniscus will not only lead to the dorsal column tract lesion, will also lead to the anterior spinothalamic tract lesion as well. And if obviously, needless to say, effect on what side? Effect is on the contralateral side because it is decussated. And then we got the third order neuron from the thalamic radiation. Same story. Part of corona aorta, the thalamic radiation, which will project into the different part of the cerebral cortex, the thalamic radiations. Third order neuron. We still have some questions to be answered there, but let me just first quickly recap this. Dorsal root ganglia from the upper and lower limb. Obviously, lower limb fibers will be coming from below, and upper limb fiber will be starting here and then only in the cervical region. Will be ascending upward, reaching the going directly into the fasciculus gracilis and cuneatus, that is in the white matter only, unlike other tracts. They keep on ascending on the same side. They have to ascend on the same side because they are first order neuron. And instead of relaying somewhere in the spinal cord, they found their nuclei in the medulla oblongata, which is nucleus gracilis and nucleus cuneatus. End of the first order neuron, second order neuron starts, forms internal arcuate fiber, goes to the other side, forms a lemniscus called as medial lemniscus, which is also joined by the anterior spinothalamic tract, relays into the VPL nucleus of thalamus, and ultimately thalamic radiation reaches the sensory cortex. Now, if I again take you back to the lower part here, guys, the question which is unanswered here is that we do have a nuclei present here in the spinal cord. They did not come to this nuclei. Now, this is nucleus proprius I'm talking about, the largest nucleus, NP, nucleus proprius. Well, yes, we do have some fibers coming to nucleus proprius also. What the point is, there are very few fibers from the lower limb and few fibers from the upper limb. They will come to nucleus proprius, but the purpose is different here. The sensation which is coming from outside is supposed to go above, that is fine. But there are very few fibers from there. They also come to nucleus proprius because from here, the interneurons will come out and that will connect to the ventral horn. Why ventral horn? Because in the ventral horn, we have the nuclei which will give rise to the lower motor neuron. So what does it tell me? It tells me that the reason few fibers came inside, although sensation has gone above, the reason few fiber came inside and relayed there, so that from there the interneuron can come here, and from the ventral horn the lower motor neuron can go out. That can keep this reflex arc maintained. If there is no relay at all in the nucleus proprius, that means there is no information given to the spinal cord gray matter, then how will you maintain the reflex arc? You will never get the reflex for sensation like for the conscious proprioception or for the pressure or for the vibration. We do have reflex or at least response to these, and that is possible because some fibers will come and relay at the nucleus proprius and then to the lower motor neuron, maintaining the reflex arc. So guys, that is about the dorsal column tract. With that, we are done with two lemniscus. Which two lemniscus? We're done with the spinal lemniscus already, and now the medial lemniscus as well. Third and the last major ascending tract is the spinocerebellar tract. Now this one is also very interesting, the spinocerebellar tract, because the tract is going to start at the level of spinal cord, and this time no thalamus, no cerebrum, it needs to go into the cerebellum. It has to go into cerebellum. So from the spinal cord into cerebellum. But how any tract can go inside or outside the cerebellum is via three white matter bundle which is connecting the cerebellum to the brainstem, and those are called as cerebellar peduncles. Previously we talked about the cerebral peduncle. This is cerebellar peduncle. Now imagine, let's say this here is the cerebellum, the cerebellar hemisphere. I'm just looking at one side here, And here we have the three white matter bundle. One is called a superior cerebellar peduncle. Then we have middle cerebellar peduncle. And let's say this one here is the inferior cerebellar peduncle. I'm writing in short, guys, SCP, superior cerebellar. Just make sure and write it. It's cerebellar. Superior cerebellar peduncle, middle cerebellar, and inferior cerebellar peduncle. These peduncles are to be discussed in detail in the cerebellum, but at least in this discussion, I should know that from the spinal cord, when the tracts will come, they will go into which part of the, which they will enter into the cerebellum through which peduncle. So we have three of them: superior, middle, inferior. And why we have three? Because they are connecting the respective part of the brainstem. Superior cerebellar peduncle is a direct connection to the midbrain, middle to the pons, and inferior to the medulla oblongata. So guys, it's pretty simple. I mean, if you think of a tract coming from cerebellum into medulla oblongata, so that will go through the inferior cerebellar peduncle or will come from the inferior cerebellar peduncle. If it is pons, it will take the pathway of middle, and if it is midbrain, it will take the pathway of superior cerebellar. Three part of brainstem, three peduncles. Now, once again, if I just put a midline here in the lower part only, let's put a midline. We should draw it slightly below, and this here again is the spinal cord. Obviously, we are talking about the tracts going into cerebellum, so it's the unconscious proprioception that we need to focus on. So unconscious proprioception will again be coming from where? From the dorsal root ganglia. That's our go-to first order neuron. That is the dorsal root ganglia, first order neuron. This dorsal root ganglia will come into the gray matter of the spinal cord. So there must be some nuclei there. And I hope you remember there was a nuclei called as a nucleus dorsalis. In the spinal cord, there's a nucleus called as a nucleus dorsalis. I would want you to write this name separately. We don't want to clutter this diagram. This is the nucleus dorsalis, which I have drawn with a red color there. Nucleus dorsalis. And that's the first order neuron is going to end there. So carrying unconscious proprioception inside and brings it there. Now let me point out, guys, these dorsal root ganglia, the one which I'm pointing at right now, they are the one which are carrying the unconscious proprioception from upper limb, lower limb, from everywhere, goes to the nucleus dorsalis, and the first order neuron is ending there. Now from this point, the second order neuron will begin, but those second order neuron will run in two different sets. Now whether the set is running on the same side or going to the other side, ultimately they have to reach the cerebellum. So my point is that what you need to keep an eye on, that which tract is running on what side and how exactly it reaches the cerebellum. Now let's do it this way. There are two ways to reach the cerebellum here. One is the shortest possible pathway to reach the cerebellum, and one is a long pathway or longest possible pathway. Let's trace a shortest one. How will you take a shortest pathway to go from here into cerebellum? So fibers will go to the same side or to the opposite side? To the same side. So second order neuron will run from there and come to the same side. Then from there, they will ascend upward in the brainstem, and once they reach the medulla oblongata only, not any further, in the medulla oblongata only, they will turn through the inferior cerebellar peduncle and goes inside the cerebellum. Like that's the shortest possible pathway to reach there. And this tract here is called as the dorsal spinocerebellar tract. I'm writing in short, guys, DSCT, dorsal spinocerebellar tract. D for dorsal, D for direct. D for dorsal, D for direct. The one which just directly goes inside the cerebellum on the same side. The second one is the ventral spinocerebellar tract. Now what ventral will do, now look at this, guys. Ventral spinocerebellar tract fibers will decussate to the other side, decussate to the upper side first of all, then they will ascend upward throughout the brainstem. That means they will cross the spinal cord, then medulla, then pons, then midbrain, and then they again comes back to the same side only and enter through which peduncle? Through the superior cerebellar peduncle. So you can see it's a very, very long or a vague course, and that's why, or you can remember it, that is called as ventral spinocerebellar tract. I believe in some hints which will remind you of these, like I said, D for dorsal spinocerebellar tract, V for ventral spinocerebellar tract. D for dorsal, D for direct, the one which will directly take the route and goes in. V for ventral spinocerebellar tract, V for vague. It takes a very vague course, goes to the other side, crosses the entire brainstem, and then again comes to the same side only. Now the question is that if ventral spinocerebellar tract has to come to the same side only, to let's say through this cerebellar hemisphere, then why it went to the other side? Why can't it come like a dorsal spinocerebellar only? So there has to be some reason that, or some purpose which is this ventral spinocerebellar tract might be having, because it is going to the other side, and that is when it runs on the opposite side, it gives collateral to the opposite cerebellar hemisphere, passing through all the cerebellar peduncle. Look at this. These are cerebellar peduncle of the other side here. Opposite cerebellar hemisphere. So ventral spinocerebellar tract, yes, it comes to the same side, but it also gives some collateral to the opposite cerebellar hemisphere, and that is very much needed. See, cerebellum is responsible for the coordination of the movement. How will cerebellum know, controls the coordination, if one side cerebellum doesn't know what is happening on the other side? We usually say cerebrum controls the contralateral body. If my right cerebrum is responsible for controlling the left side of the body, and left is controlling the right side of body, right? Because our pyramidal tract decussate, that's what we say. But cerebellum controls ipsilateral body, guys. My right cerebellum works for right side of the body, and left cerebellum works for the left side of the body. And you will understand that in the cerebellum better. But the point is, if only sensory fibers, if only the unconscious proprioception is coming from one side, is going to one side cerebellum only, and we don't know what is happening to the other side of the body, then we can never compare them. And if we can't compare them, then we can never balance it, because the main function of cerebellum is the comparison. That's why we say comparator function. Cerebellum is having a comparator function, and comparison is only possible when you have the fibers coming from both the sides. So thankfully we have ventral spinocerebellar tract, which carries the information and brings it and gives it to both the cerebellar hemisphere. Now another question here, is this the only function of ventral spinocerebellar? Is this the only difference between the dorsal and ventral spinocerebellar tract? No, this is not the only difference. We have some other difference also. Dorsal spinocerebellar tract is known for the precise unconscious proprioception, a very precise unconscious proprioception from individual muscle or something like that. But ventral spinocerebellar tract, as I already used the word vague, it is carrying the unconscious proprioception from that region as a whole. If I'm doing the elbow flexion, this compound movement which is taking place at the elbow, during the elbow flexion, muscles are working and the sensory fibers are coming from the joint. So that type of vague information from the joint is coming through the ventral spinocerebellar tract. So precise one is dorsal and vague is this ventral. But there is a catch here. Ventral spinocerebellar tract. Now that's a very important point. I wanted to understand this very well, guys. Ventral spinocerebellar tract is the tract which is carrying this vague information from the lower limb as well as upper limb. That means both, from everywhere. But dorsal spinocerebellar tract is carrying this information only from lower limb. That means we do not have dorsal spinocerebellar tract for the upper limb. Or in other words, we do not have a tract to carry precise unconscious proprioception for the upper limb. Well, how is it possible? We must be having some tract for that. There is. Well, what tract is that? For upper limb, the difference is, guys, for the upper limb, the precise unconscious proprioception for the upper limb. I'm writing DRG once again. And this time we are talking about the unconscious proprioception from upper limb. If I just focus on the upper limb part, so what upper limb fibers will do, these dorsal root ganglia fiber which are coming from the upper limb, they will go directly into the white matter of the spinal cord. So this is to be understood very well. They did not go to the nucleus dorsalis there. Ideally they should, But those fibers which are carrying the precise unconscious proprioception of upper limb, they directly go into the white matter. Now it's a choice for you. In the white matter, in the dorsal side, we have either fasciculus gracilis or fasciculus cuneatus. Now, according to you, these fibers should join with which one? Gracilis or cuneatus? Well, because they're coming from where? From the upper limb. So they will join with the cuneatus fiber. So these fibers, they merge with the cuneatus fiber only and they will run above like this. That means this is still what? That is fasciculus cuneatus. Which order neuron still? First order neuron. So precise unconscious proprioception from the upper limb through the dorsal root ganglia goes directly into the fasciculus cuneatus, ascend upward. So that means there is no relay till now. Well, without relay, you are not going to go inside the cerebellum. You have to relay somewhere. So what happens is, in the medulla oblongata, there is a nucleus present for this tract, and that nucleus, before I tell you the name of this nucleus, I should show it to you in the previous picture. That nucleus is present very, very close to nucleus cuneatus. Just look here, guys, for 1 second. Look at this tract we discussed here. When we're talking about the previous tract, we said fasciculus gracilis and cuneatus will go into medulla oblongata, into nucleus gracilis and nucleus cuneatus. That is nucleus cuneatus. So very, very close to nucleus cuneatus. In fact, the detached part of nucleus cuneatus, there is another nucleus there, and that is called as accessory cuneate nucleus. It's called as ACN, accessory cuneate nucleus. It's a detached part of nucleus cuneatus only, accessory cuneate nucleus, which is also present in medulla oblongata only, and that is the one we are talking about right now. So this here is ACN, that is an accessory cuneate nucleus, from which the second order neuron will come and they will enter again through the same inferior cerebellar peduncle, which makes sense because accessory cuneate nucleus is present in medulla oblongata, and if a fiber is coming from medulla oblongata and it has to go inside the cerebellum, it obviously will go from which peduncle? Inferior cerebellar peduncle only. So guys, what should be the name of this tract? It is coming from accessory cuneate nucleus. This tract is called as a cuneo-cerebellar tract. This tract is called as a cuneo-cerebellar tract. And this cuneo-cerebellar tract was carrying the precise unconscious proprioception from upper limb. This is called as the cuneo-cerebellar tract. Now I know there is one question which might be coming to your mind, and I'll resolve that. Just get over with this first. So dorsal spinocerebellar tract, you can imagine it is the dorsal one. Let's say it is for the lower limb only, carrying the lower limb unconscious proprioception and taking through the inferior cerebellar peduncle. Upper limb unconscious proprioception, precise one, is coming separately through fasciculus cuneatus, accessory cuneate nucleus, and cuneo-cerebellar tract, again through inferior cerebellar peduncle. So the purpose of ventral spinocerebellar tract is altogether different. That is carrying the vague information and giving it to both the cerebellar hemisphere, so that at least the cerebellum of both the side will know what is happening to the other side. See, when you walk, let's take an example. When you walk, you sway your hand. Your one hand goes in front and your other hand goes behind, and it keeps happening alternatively. I mean, it's not like that both the hand will keep on swaying forward and both the hand will go backward simultaneously, because my right cerebellum is not only aware of what is happening on the right side, it is also aware of what is happening on the left side. So this information, they keep on exchanged, and then only you can actually maintain this body equilibrium or the posture. Well, the question which might be coming to your mind is about the fasciculus, because in this discussion here we said fasciculus gracilis and cuneatus, they are carrying conscious proprioception. Dorsal column tract is about conscious proprioception. And now I'm saying this fasciculus cuneatus is carrying unconscious proprioception from the upper limb. So which one is true? Is fasciculus cuneatus carrying one or it is carrying both? It is carrying both. That's the difference, guys. If there is injury to fasciculus gracilis or if there is injury to fasciculus cuneatus, the effect will be a bit different here. Let's understand this in this manner. Now imagine if this is a spinal cord here, just to make you understand, you can just draw it very roughly here. This here is the midline. Now when you saw fasciculus gracilis fibers, they will come in like this, they will go in there, relay into some nucleus. Cuneatus fiber will also come like this, relay in certain nucleus, that is nucleus gracilis, nucleus cuneatus, And you know the rest of the story. I don't have to draw the entire part. Internal arcuate fiber and so on. That is dorsal column tract. This was fasciculus gracilis toward the medial side and cuneatus toward the lateral side. And they were both carrying what? They were both carrying what? Conscious proprioception. Now comes unconscious proprioception, but from where? From upper limb. That unconscious proprioception from the upper limb will join with the fasciculus cuneatus, ascend upward, but not going to that nucleus. It is deviating into the nucleus cuneatus. And from there, it was going as from the accessory cuneate nucleus, it was going as a cuneo-cerebellar tract into the inferior cerebellar peduncle. This is what we discussed. I'm just joined both the tracts here, guys. This is accessory cuneate nucleus here. This is nucleus gracilis and that is nucleus cuneatus. Now, what I want you to focus on, look at this. This here is fasciculus gracilis, but both these bundles that you're looking at, they are in fasciculus cuneatus. And that is the whole point. Because the red colored fiber which I drew, they are the one carrying the unconscious proprioception from the upper limb. So let's say, let me put it in a clinical way. If the question says there is injury to fasciculus gracilis, only if there is injury to fasciculus gracilis, then obviously you will say there is a loss of conscious proprioception or vibration or whatever it is, but from the same side. And where? From the lower limb. Gracilis is carrying from the lower limb. Let me write that for you. If there is injury to fasciculus gracilis, there will be ipsilateral loss of conscious proprioception, vibration, etc., whatever is there in the dorsal column tract. From where? From lower limb. That's the main point, from lower limb. But if there is injury to fasciculus cuneatus, now that's entirely different. If there is injury to fasciculus cuneatus, this will lead to the ipsilateral loss of, again same thing, only conscious proprioception, vibration, etc., plus unconscious proprioception also. From where? From upper limb. From where? From upper limb. So the point to be noted here is that if there is injury to fasciculus cuneatus, we not only have loss of conscious proprioception, we also will have a loss of unconscious proprioception because unconscious proprioception from the upper limb was joining with the fasciculus cuneatus and then separating in the upper part and going to the accessory cuneate nucleus and then to the cerebellum. So injury to gracilis, lower limb, same side, conscious proprioception is lost. Fasciculus cuneatus injury, both conscious and unconscious from the upper limb from the same side is lost. So that's an important thing to understand from here. So guys, this is about the three major ascending tracts, and as I said, the very important thing in the tracts is to especially remember that where they are decussating here. So the two tracts which we talked about mainly, see that's a spinocerebellar tract we just discussed, and spinocerebellar tract, it doesn't decussate. I mean, only ventral spinocerebellar tract is decussating, but just to come to the same side. Otherwise, when you think of decussation, it is either dorsal column tract or the spinothalamic tract which was decussating. Three major ascending tract, done.